Hello, my name is Dr. Sunil Gupta and this is the third podcast on the Handbook of COVID-19 Prevention and Treatment published by Zhejiang University School of Medicine, China on the 18th of March 2020. This third podcast is on part 3 of the handbook, which is on nursing. There are previous podcasts on part 1, prevention and control management, and part 2, diagnosis and management. First, a disclaimer, this PowerPoint is copied from the Handbook of COVID-19 Prevention and Treatment. It is written to help spread the invaluable experience of healthcare colleagues in China at a time when helpful information is urgently and desperately needed. Understandably, the handbook was written at great speed, so there is a possibility that there may be some errors and defects. I would strongly recommend you seek advice from your national professional organisations and the World Health Organization for the latest evidence-based advice. So part 3 of the handbook on nursing is divided into 5 sections. Section 1, nursing care for patients receiving high-flow nasal cannula oxygen therapy. Section 2, nursing care for patients with mechanical ventilation. Section 3, daily management and monitoring of ECMO patients. Section 4, nursing care of patients having artificial liver support system. And Section 5, continuous renal replacement treatment care. And this podcast will also contain a summary for the management of patients with mild, moderate, severe and critical COVID-19. So first, starting off with Section 1, nursing care for patients receiving high-flow nasal cannula oxygen therapy. And that's divided into 1.0 assessing, 2.0 monitoring and 3.0 treatment of secretions. So starting with assessing, provide detailed information of the HFNC oxygen therapy to get the patient's cooperation before implementation. Use low-dose sedative with close monitoring if necessary. Choose a proper nasal catheter based on the diameter of the patient's nasal cavity. Adjust the head strap tightness and use decompression plaster to prevent device-related pressure injuries on the facial skin. Maintain the water level in the humidifier chamber. Titrate the flow rate, the fraction of inspired oxygen, i.e. FiO2, and the water temperature based on the patient's respiratory demands and tolerance. 2.0 monitoring. Report to the attending physician to seek medical decision of replacing HFNC by mechanical ventilation if any of the following occur: hemodynamic instability, respiratory distress evidenced by obvious contraction of accessory muscles, hypoxemia persists despite oxygen therapy, deterioration of consciousness, the respiratory rate greater than 40 breaths per minute continuously, significant amount of sputum. 3.0 treatment of secretions. Patient's drool, snot and sputum should be wiped with tissue paper, be disposed in a sealed container with chlorine-containing disinfectant at a concentration of 2,500 milligrams per litre. Alternatively, secretions can be removed by oral mucus extractor or suctioning tube and be disposed in a sputum collector with chlorine-containing disinfectant at 2,500 milligrams per litre. Now come on to Section 2, nursing care for patients with mechanical ventilation, which is divided into 1, intubation procedures, 2, analgesia, sedation and delirium management, 3, prevention of ventilation-associated pneumonia, 4, sputum suction, 5, disposal of condensation from ventilators, 6, nursing care for the prone position ventilation. Starting with 1.0 intubation procedures. The number of the medical staff should be limited to the minimum number that can ensure the patient's safety. Wear powered air purifying respirator as personal protection equipment. Before intubation, perform administration of sufficient analgesia and sedative and use muscle relaxant if necessary. Closely monitor the hemodynamic response during intubation. Reduce movement of staff in the ward. continuous purify and disinfect the room with plasma ear purification technology for 30 minutes after completion of intubation. 2.0 Analgesia, sedation and delirium management. Determine the target pain management goal every day. Assess pain with every 4 hours, i.e. critical care pain observation tools, CPOT. Measure sedation every 2 hours with RASS/BISS. Titrate the infusion rate of analgesics and sedatives to achieve pain management goals. For the known painful procedures, preemptive analgesia is administered. Perform CAM, ICU delirium screening in every shift to ensure an early diagnosis. Apply centralization strategy for delirium prevention, including pain relief, sedation, communication, quality sleep, and early mobilization. 3.0 Prevention of ventilation-associated pneumonia. The ventilator bundle is used to reduce ventilation-associated pneumonia, which includes hand washing, raising the tilt angle of the patient's bed by 30 to 45 degrees if no contraindication is present, oral care every 4 to 6 hours by using a disposable oral mucus extractor, maintain endotracheal tube cuff pressure at 30 to 35 centimeters of water every 4 hours, enteral nutrition support and monitor gastric residual volume every 4 hours, evaluating daily for ventilator removal, using washable tracheal tubes for continuous subglottic suctioning combined with 10 ml syringe suctioning every 1 to 2 hours and adjusting the suctioning frequency according to the actual amount of secretions. Dispose retentate below the glottis. The syringe containing the subglottic secretions is immediately used to aspirate an appropriate amount. Chlorine containing disinfectant then recapped and disposed of in a sharp container. 4.0 Sputum Suction. 1. Use a closed sputum suction system, including closed suction catheter and closed disposable collection bag to reduce the formation of aerosol and droplets. 2. Collection of sputum specimen. Use a closed suction catheter and a matching collection bag to reduce exposure to droplets. 5. Disposal of condensation from ventilators. Use disposable ventilator tubing with dual loop heating wire and automatic humidifier to reduce the formation of condensation. 2 nurses should cooperate to dump the condensation promptly into a capped container with chlorine-containing disinfectant, 2,500 mg per litre. The container can then be directly put in a washing machine which can be heated up to 90 degrees for automatic cleaning and disinfection. 6. Nursing care for the prone position ventilation. Before changing position, secure the position of tubing and check all the joints to reduce the risk of disconnection. Change the patient's position every 2 hours. Now come on to Section 3, Daily Management and Monitoring of Patients on ECMO, extracorporeal membrane oxygenation. 1. ECMO equipment should be managed by ECMO perfusionists and the following items should be checked and recorded every hour. Pump flow rate stroke rotation speed, blood flow, oxygen concentration, ensuring that the temperature controller is flowing, temperature setting and actual temperature, preventing clots in circuit, no pressure to the cannulae and the circuit tubing is not kinked, no shaking of ECMO tubes, patient's urine colour with special attention to red or dark brown urine, pre and post membrane pressure as required by the doctor. 2. The following items during each shift should be monitored and recorded. Check the depth and fixation of cannula to ensure that the ECMO circuit interfaces are firm, the water level line of the temperature controller, the power supply of the machine and the connection of the oxygen, the cannula site for any bleeding and swelling, measure leg circumference and observe whether the lower limb on the operation site is swollen, observe lower limbs such as dorsalis pedis, arterial pulse, skin temperature, colour, etc. 3. Daily monitoring, post-membrane blood gas analysis. 4. Anticoagulation management. The basic goal of ECMO anticoagulation management is to achieve a moderate anticoagulation effect, which ensures that certain coagulation activity under the premise of avoiding excessive activation of coagulation. That is to maintain the balance amongst anticoagulation, coagulation and fibrinolysis. The patient should be injected with heparin sodium 25 to 50 IU per kilogram at the time of intubation and maintained with heparin sodium 7.5 to 20 IU per kilogram per hour during the pump flow period. The dosage of heparin sodium should be adjusted according to the IPTT results, which should be held between 40 to 60 seconds. During the anticoagulation period, the number of skin punches should be reduced as less as possible. Operations should be taken gently. The status of bleeding should be observed carefully. 5. Implement the ultra-protective lung ventilation strategy to avoid or reduce the occurrence of ventilator-related lung injury. It is recommended that the initial tidal volume is less than 6 milliliters per kilogram and the intensity of spontaneous breathing is retained, i.e. breathing frequency should be between 10 to 20 times per minute. 6. Closely observe the vital signs of patients. Maintain MAP between 60 to 65 millimeters of mercury, CVP less than 8 millimeters of mercury, SpO2 greater than 90%, and monitor the status of urine volume and blood electrolytes. 7. Transfuse through the post-membrane, avoiding infusion of fat emulsion and propofol, PROPOFOL. 8. According to the monitoring records, evaluate the ECMO oxygenator function during every shift. Now come on to section 4, nursing care of artificial liver support system. Artificial liver support system nursing care is mainly divided into two different periods: nursing care during treatment and intermittent care. Nursing staff should closely observe the conditions of patients, standardize the operating procedures, focus on key points, and deal with complications timely in order to successfully complete ALSS treatment. So it's divided into 1.0 nursing care during treatment and 2.0 intermittent care, starting with 1.0 nursing care during ALSS treatment. It refers to nursing during each stage of ALSS treatment. The overall operation process can be summarized as follows: operator's own preparation, patient evaluation, installation, pre-flushing, running, parameter adjustment, weaning and recording. The following are the key points of nursing care during each stage. 1. Operator's own preparation. Fully adhere to level 3 or even more strict protective measures. 2. Patient assessment. Assess the patient's basic conditions, especially allergy history, blood glucose, coagulation function, oxygen therapy, sedation. For sober patients, pay attention to their psychological state and catheter function status. 3. Installation and pre-flushing. Use consumables with closed-loop management while avoiding the exposure to patients' blood and body fluids. The corresponding instruments, pipelines and other consumables should be selected according to the planned treatment mode. All basic functions and characteristics of the consumable should be familiarized. 4. Running. It is recommended that the initial blood draw speed is less than or equal to 35 milliliters per minute to avoid low blood pressure, which might be caused by high speed. Vital signs should be monitored as well. 5. Parameter adjustment. When the patient's extracorporeal circulation is stable, all treatment parameters and alarm parameters should be adjusted according to the treatment mode. A sufficient amount of anticoagulant is recommended in the early stage, and the anticoagulant dose should be adjusted during the maintenance period according to the different treatment pressure. 6. Weaning. Adopt liquid gravity combined recovery method. The recovery speed less than or equal to 35 milliliters per minute. After weaning, medical waste should be treated in accordance to the SARS-CoV-2 infection prevention and control requirements, and the treatment room and instruments should be cleaned and disinfected as well. 7. Recording. Make accurate records of the patient's vital signs, medication and treatment parameters for ALSS and take notes on special conditions. Now come on to 2.0, intermittent care during ALSS treatment. 1. Observation and treatment of delayed complications, i.e. allergic reactions, imbalance syndromes, etc. 2. ALSS intubation care. Medical staff during each shift should observe the patient's conditions and make records, prevent catheter-related thrombosis, carry out professional maintenance of the catheter every 48 hours. 3. ALSS intubation and extubation care. Vascular ultrasonography should be performed before extubation. After extubation, the lower limb with the intubation side of patients should not be moved in 6 hours, and the patient should rest in bed for 24 hours. After extubation, the surface of the wound to be observed. Now come on to section 5, continuous renal replacement treatment care and the nursing involved with that, which is divided into 1. Preparation before continuous renal replacement treatment, 2. In-treatment care, 3. Postoperative care. 1. Preparation before CRRT. Preparation for patient. Establish effective vascular access. Generally, central vein catheterization is performed for CRRT, with the internal jugular vein preferred. A CRRT device can be integrated into the ECMO circuit if the two are applied at the same time. Prepare equipment, consumables and ultrafiltration medication before CRRT. In 2.0, in-treatment care. 1. Vascular access care. Perform professional catheter care every 24 hours for patients with central venous catheterization to properly fix access to avoid distortion and compression. When CRRT is integrated into ECMO treatment, the sequence and the tightness of the catheter connection should be confirmed by 2 nurses. Both the outflow and the inflow CRRT lines are suggested to be connected behind the oxygenator. 2. Closely monitor consciousness and the vital signs of patients. Accurately calculate the fluid inflow and outflow. Closely observe blood clotting within the cardiopulmonary bypass circuit. Respond effectively to any alarms and ensure that the machine is operating properly. Assess the electrolyte and acid-base balance in the internal environment through blood gas analysis every 4 hours. The replacement liquid should be prepared freshly and labelled clearly under strict sterile conditions. 3. Postoperative care. 1. Monitor blood routine, liver and kidney function and coagulation function. 2. Wipe the CRRT machine every 24 hours if continuous treatment is applied. Consumables and wasted liquid should be disposed in accordance with hospital requirements to avoid nosocomial infection. Now come on to Part 6, General Care. 1. Monitoring. Patient vital signs should be continuously monitored, especially changes in consciousness, respiratory rate and the oxygen saturation. Observe symptoms such as cough, sputum, chest tightness, dyspnea and cyanosis. Monitor arterial blood gas analysis closely. Timely recognition of any deterioration to adjust strategies of oxygen therapy or to take urgent response measures. Pay attention to ventilator-associated lung injury when under high positive end expiratory pressure, PEEP, and high pressure support. Closely monitor changes in airway pressure, tidal volume, and respiratory rate. 2. Aspiration prevention. 1. Gastric retention monitor. Perform continuous post-pyloric feeding with a nutrition pump to reduce gastroesophageal reflux. Evaluate gastric motility and gastric retention with ultrasound if possible. Patients with normal gastric emptying are not recommended for routine assessment. 2. Evaluate gastric retention every 4 hours. Reinfuse the aspirate if the gastric residual volume is less than 100 milliliters. Otherwise, report to the attending physician. 3. Aspiration prevention during patient transportation. Before transportation, stop nasal feeding, aspirate the gastric residues and connect the gastric tube to a negative pressure bag. During transportation, raise the patient's head up to 30 degrees. 4. Aspiration prevention during HFNC. Check the humidifier every 4 hours to avoid excessive or insufficient humidification. Remove any water accumulated in the tubing promptly to prevent cough and aspiration caused by the accidental entry of condensation into the airway. Keep the position of the nasal cannula higher than the machine and tubes. Promptly remove condensation in the system. 3. Implement strategies to prevent catheter-related bloodstream infection and catheter-related urinary tract infection. 4. Prevent pressure-induced skin injuries, including device-related pressure-induced injuries, incontinence-associated dermatitis, and medical adhesive-related skin injuries. Identify patients at high risk with the risk assessment scale and implement preventative strategies. 5. Assess all patients upon admission and when their clinical conditions change with the venothromboembolism risk assessment model to identify those who are at high risk and implement preventative strategies. Monitor coagulation function, D-dimer levels, and VTE-related clinical manifestations. 6. Assist eating for patients who are weak, short of breath, or those with an obvious fluctuating oxygenation index. Intensify oxygenation index monitoring on these patients during meals. Provide enteral nutrition at early stages for those who are unable to eat by mouth. During each shift, adjust the enteral nutrition rate and quantity according to the tolerance of enteral nutrition. Now come on to the appendix, and which is the medical advice of mild, moderate, severe and critical COVID-19 patients. Starting with the medical advice of mild COVID-19 patients. 1.1 Ordinary. Ear isolation, blood oxygen saturation monitoring, oxygen therapy with nasal cannula. 1.2 Examinations. So 2019 novel coronavirus RNA detection, 3 sites sputum once a day. 2019 novel coronavirus RNA detection, 3 site feces once a day. Blood routine, biochemical profile, urine routine, stool routine plus OB, coagulation function plus D-dimer. Blood gas analysis plus lactic acid, ASO plus RF plus CRP plus CCP, ESR, PCT, ABO and rhesus blood type, thyroid function, cardiac enzymes, and quantitative assay of serum troponin. 4 routine items: respiratory virus test, cytokines, G/GM test, angiotensin converting enzyme. Other examinations are gallbladder, pancreas and spleen ultrasound, echocardiography and lung CT scan. Medication: Arbidol, ARBIDOL, tablets 200 milligrams by mouth 3 times a day. Lopinavir, LOPINAVIR, stroke ritonavir, RITONAVIR, 2 tablets by mouth every 12 hours. Interferon spray, 1 spray, PRTID. So 2.0 medical advice of moderate COVID-19 cases. So 2.1 ordinary, ear isolation, blood oxygen saturation monitoring, oxygen therapy with nasal cannula. 2.2 examinations. 2019 novel coronavirus RNA detection, 3 sites sputum once a day. 2019 novel coronavirus RNA detection, 3 sites feces once a day. Blood routine, biochemical profile, urine routine, stool routine plus OB, coagulation function plus D-dimer, blood gas analysis plus lactic acid, ASO plus RF plus CRP plus CCP, ESR, PCT, ABO and rhesus blood type, thyroid function, cardiac enzymes and quantitative assay of serum troponin. 4 routine items: respiratory virus test, cytokines, G/GM test, angiotensin converting enzymes, and liver, gallbladder, pancreas and spleen ultrasound, echocardiography and lung CT scan. Medication: Arbidol, tablets 200 milligrams by mouth TID. Lopinavir, stroke ritonavir, 2 tablets by mouth every 12 hours. Interferon spray, 1 spray, PRNAR 3 times a day. And the 4th medication for patients with moderate COVID-19 cases is NS 100 milliliters plus Amboxol, AMBROXOL 30 milligrams IV GTT twice a day. 3.0 medical advice of severe COVID-19 cases. 3.1 ordinary air isolation, blood oxygen saturation monitoring, oxygen therapy with nasal cannulae. 3.2 examinations, 2019 novel coronavirus RNA detection 3-site sputum QD, 2019 novel coronavirus RNA detection 3-site feces once a day. Blood routine, biochemical profile, urine routine, stool routine plus OB, coagulation function plus D-dimer, blood gas analysis plus lactic acid, ASO plus RF plus CRP plus CCP plus ESR, PCT, ABO and rhesus blood type, thyroid function, cardiac enzyme, quantitative assay of serum troponin, 4 routine tests, respiratory virus tests, cytokines, G/GM test, angiotensin converting enzymes, and liver, gallbladder, pancreas and spleen ultrasound, echocardiography and lung CT scan. Medications: Arbidol tablets 200 milligrams 3 times a day, lopinavir/ritonavir 2 tablets by mouth every 12 hours, interferon spray 1 spray PR.NAR 3 times a day, NS 100 milliliters plus methylprednisolone 40 milligrams IV GTT once a day, NS 100 milliliters plus pantoprazole PANTOPRAZOLE 40 milligrams IV GTT once a day, Caltrate CALTRATE 1 tablet once a day, immunoglobulin 20 grams IV GTT once a day, and the final thing is NS 100 milliliters plus Ambroxol AMBROXOL 30 milligrams IV GTT twice a day. Now come on to the 4.0 medical advice of critical COVID-19 cases. 4.1 ordinary air isolation, blood oxygen saturation monitoring, oxygen therapy with nasal cannula. 4.2 examinations: 2019 novel coronavirus RNA detection 3-site sputum once a day, 2019 novel coronavirus RNA detection 3-site feces once a day. Blood routine, ABO plus rhesus blood type, urine routine, stool routine plus OB, 4 routine items: respiratory virus test, thyroid function, electrocardiogram, blood gas analysis plus electrolyte plus lactic acid plus GS. G/GM test, blood culture once. Blood routine, biochemical profile, coagulation function plus D-dimer, blood gas analysis plus lactic acid, natriuretic peptide, cardiac enzyme, quantitative assay of serum troponin, immunoglobulin plus complement, cytokine, sputum culture, CRP, PCT, QD. Blood glucose measurement every 4 hours, liver, gallbladder, pancreas and spleen ultrasound, echocardiogram and lung CT scan. And the medication for critical COVID-19 cases are Arbidol tablets 200 milligrams by mouth 3 times a day, lopinavir/ritonavir 2 tablets every 12 hours, or darunavir DARUNAVIR 1 tablet once a day. NS 10 milliliters plus methylprednisolone 40 milligrams IV every 12 hours. NS 100 milliliters plus pantoprazole 40 milligrams IV GTT once a day. Immunoglobulin 20 grams IV GTT once a day. Thymic peptides 1.6 milligrams IH twice a week. NS 10 milliliters plus Ambroxol AMBROXOL 30 milligrams IV twice a day. NS 50 milliliters plus isoproterenol ISOPROTERENOL 2 milligrams IV VP once. Human serum albumin 10 grams IV GTT once a day. NS 100 milliliters plus piperacillin PIPERACILLIN stroke tazobactam TAZOBACTAM 4.5 IV GTT every 8 hours. Enteral nutrition suspension, Pectosorb liquid, PTISORB liquid, 500 milliliters nasogastric feeding twice a day. Then there's other things from the handbook, which includes the online consultation for diagnosis and treatment, and the online doctor's communication profile, and there's some information about the editorial board and the references from the handbook. So this presentation was on part 3 of the handbook, which is on prevention and management, and the part 3 and this podcast discuss nursing, but there's also podcasts on part 1, which is prevention and control, and part 2, which is diagnosis and management. But I'd strongly recommend you look at the latest version of the handbook. Thank you very much.